What I'd like to cover over the next few minutes are in four broad categories. The presentation, who our patients were, what they presented with, some clinical characteristics, organ dysfunction, and we'll focus on four major organ dysfunctions in that subgroup, and then a brief idea of short-term outcomes. So starting with clinical characteristics, our patients presented to the ICU in one of two ways. One, they had onset of symptoms after 3 or 4 days. They presented to the emergency room with cough, fever, shortness of breath, and were slightly hypoxic to normoxemic in the EDs and were admitted to the floor. What we commonly saw, up to 1 out of the 4 patients who were admitted to the floor had worsening hypoxia, worsening pulmonary failure on the floors, and then were admitted to the ICU as a consequence of the need for a higher level of monitoring. Many of them went on to develop severe ARDS, requiring invasive mechanical ventilation and ventilatory strategies appropriate to severe ARDS. A few days after, the ARDS seems to be stable or even improving, followed by them having a severe cytokine storm, and we'll talk about this later, following which renal failure ensued. Many of them went on to die. We'll come to the numbers in a bit, and many of them had ongoing ventilatory and renal replacement therapy needs. The other major route of entry to the ICU were patients presented to the ED with symptoms, and the symptoms were severe enough for them to mandate an ICU level of admission straight on. They were either very hypoxic or had respiratory distress or multi-organ failure at the time of their presentation to the ED. Morbidities. Strong male predominance, up to 72% of our patients were male. The common X-ray findings on admission, they were almost everybody, 80% of them had multifocal infiltrates. Barely anyone had clear X-rays. Some of them had lobar consolidations and interstitial abnormalities. And here you can see that this is the classic chest X-ray of a patient coming in with COVID pneumonia and COVID ARDS. Bilateral fluffy infiltrates. A lot of patients had multiple lines and tubes in them. As you can see here, this is an endotracheal tube or right internal jugular vein catheter, but these multifocal patchy infiltrates was almost universal in our patient population. The inflammatory surge that we saw, and I'll talk more about this in a bit, but a few days into their ICU admission, a significant proportion of our patients developed fevers, tachycardia, tachypnea, diaphoresis without, in fact, surge-like symptoms without any clear infectious etiology. And when we checked their inflammatory markers, they were all over the place. We had extremely high D-dimers, elevated ferritins, troponins as well. Elevated LDH was present in almost 100% of our patients, CRPs, IL-6s, and these were not mild perturbations of the lab values. These were CRPs in the 300-400 range, IL-6s 5-6 times above the upper limit of normal, so gross inflammation leading to a vasoplegic shock. Almost all our patients in the ICU again had ARDS. Significant number, 70% were shock state. Very few of these were septic shock. Significant number were vasoplegic shock from the cytokine storm that was just mentioned. Renal replacement, a little bit higher than we expected. 1 out of 3 patients in the ICU needed either intermittent hemodialysis, continuous veno-venous filtration, or emergent peritoneal dialysis. 20% patients needed tracheostomy, and we'll come back to this again. And unfortunately, even within this is short-term mortality, not 28-day mortality, not 1-year mortality. We were looking at a mortality rate of around 55 to 60%. And remember, these were relatively young people coming off the streets with barely any pre-existing comorbidities. So this mortality rate is much higher than what is in a traditional ICU population. The organ dysfunction that we talk about fall broadly in 4 categories: ARDS, acute respiratory distress syndrome, the cytokine storm that we were alluding to a little bit ago, renal failure, and the hypercoagulable state. Again, a lot of this, the understanding behind the pathophysiology of why this occurs and what to do about it is in evolution. So things may change. Our understanding of this disease process itself will definitely change in the weeks to months to come. This is the descriptions following is based on best current understanding of how this virus behaves. Starting with acute respiratory distress syndrome, as you saw, almost all our patients in the ICU had ARDS. Close to 50% of them had severe ARDS, the others had mild or moderate. Um, Conventional management, trial of high flow nasal cannula, we started putting our patients on HFNC. Some of them, around 20-25%, were able to stave off intubation with this. The large majority had high flow as a bridge to intubation. We intentionally kept away from non-invasive mechanical ventilation, the BiPAPs, the BiPAP devices, simply because there is pretty strong data to suggest that mortality worsens in patients who have ARDS and are treated with non-invasive ventilation. We tried our best to protect the lungs with lung protective strategy, 6 cc's per kg of ideal body weight, with permissive hypercapnia, with a CO2 55 to 60 targeted, a pH of 7.2 and above, and the permissive hypoxia with a gold SAT of 88 and above, and a gold PaO2 55 and above, 55 to 65. We were trying to follow the ARDSNet P2F ladder as much as we could. But that said, because our patients were sometimes in cytokine storm and were hypovolemic from the insensible losses, PEEP sometimes had a counterintuitive effect, as patients with higher PEEPs had worsening VQ and worsening hypoxia. Recruitment was attempted on a patient-to-patient basis, very individualized approach to PEEP titration there. Attention to fluid balance, again, very individualized. The traditional teaching of a dry lung as a happy lung was not always applicable, and we were seeing some renal failure, some worsening hemodynamics as we tried to diurese our patients aggressively. We tried antibiotics, more so as empiric in nature. Now, most of our cultures, at least early on, were negative, and after 48 hours of antibiotics with negative cultures, we were pulling off antibiotics after the first 48 hours. Our patients were very catabolic, very adrenergic, and needed high levels of sedation, um, not just fentanyl and propofol, but also ketamine and unfortunately Versed, to stay compatible with the vent. To keep them synchronous with the vent, we had to use a fair amount of neuromuscular blockade in the form of Nimbeck strips and so forth. We used inhaled NO for refractory hypoxia, and this is very topical here because often on we saw acute cor pulmonale, and were able to improve hemodynamics with the use of RB afterload reducer. We had manual proning. Significant, almost all our patients were prone responsive, and we were proning at 3 p.m. in the afternoon with the proning team, and supinating every morning at around 8 or 9 in the morning with a 16-hour prone window. And then as a salvage, when based on the Caesar and the earlier trials, based on if everything else was failing, then the lung protective strategy, the recruitment, the neuromuscular blockade, the inhaled NO, and proning, and the patients were still refractory and hypoxic, we had ECMO, VV ECMO as an option. We cannulated 5 people so far who have been on VV ECMO. 2 of them have been decannulated. 1 unfortunately has passed away. 2 of them are still on the circuit. Other issues, central lines and airlines were placed during the time of intubations. We prefer the left IJ central venous line for our venous access, keeping the right IJ for renal failure, which often are needed dialysis. We left the subclavians alone because of the risk of pneumothorax in a patient with such severe ARDS would be a pericard situation. We left the femorals alone just because of the risk of CLAPSIs in that region. As mentioned, many of them had substantial sedation requirements, and many of them needed neuromuscular blockade to achieve ventilator dysynchrony. We quickly ramped up a tracheostomy team, knowing that these patients had severe ARDS, needed deep sedation and blockade, and would require long-term weaning to come off the ventilator. We quickly formulated a surgical tracheostomy team, which was protocolized and did above 30-35 bedside perk trach so far. Our initial experiences based on existing data at that time was to try a plaquenil and azithro, but of course we watched the QT for prolongation very, very closely during the time. The second organ dysfunction, if you may, I want to allude to is the cytokine release syndrome. Very common, very surprising from a viral sepsis perspective, but almost universally in all our patients, we saw a few days into the ICU course marked fevers, tachycardia, tachypnea, diaphoresis, no obvious infectious sources despite culturing blood, sputum, urine, stool, what have you. Um, and this was the cytokine storm was manifested by extremely high CRPs, ferritins, LDHs, IL-6s, D-dimers as well, though now we realize that some of the D-dimers were a marker of hypercoagulable state and thrombosis. Many of our patients then progressed to renal failure, and we really still don't know how to mitigate the cytokine storm. We tried steroids, of course, knowing that this was a double-edged sword. With the Nimbex with the paralytics on board, the risk of neuromuscular weakness with steroids is extremely high. The risk of bacterial and fungal superinfection was high. We tried 5 days of steroids. Data will show whether it actually worked or not. We tried anti-IL-6s, tocilizumab, on select patients. But again, these I would like to emphasize are not data-driven therapies. Hopefully, over the months to come, we will actually have some data to show us what works and what does not work. Renal replacement therapy, a surprisingly high incidence of acute kidney injury in our patients, in almost all patients in the US, much higher than the literature in China suggested. Um, so we were trying CVVH in our patients who could tolerate it, and as we ran out of CVVH machines, we quickly moved to emergent PD, a peritoneal dialysis, which worked quite well to be able to provide RRT to our sick patients. And the last organ system dysfunction I'd like to just go over is the hypercoagulable state that SARS-CoV-2 brings with it. Up to 25-30% of our patients had uh, um, a reason to initiate therapeutic anticoagulation, and as in real time we were seeing a lot of clots. People were uh, becoming hypotensive with blown out RVs and clots in transit as we echoed and focused them at the bedside. And this was in the setting of therapeutic anticoagulation with heparin or Lovenox. Now, again, unclear etiology, autopsy studies suggest that there is a virus-induced endothelial damage, inflammatory cascade follows. We were using the D-dimer as a surrogate of clot formation, given that transporting a patient with COVID to the CT scanner and back, or getting Doppler to the CT scanner and back was difficult. We did a lot of point of care Doppler ultrasounds to look for objective clot in the FEMS, in the lower extremities, but only 2 or 3 of them were positive. So we were able to we were initiating therapy with therapeutic anticoagulation based on D-dimers to a large extent. Other considerations against, again, I want to emphasize there is no evidence-based treatment yet. Critical care support is the mainstay of therapy. There is some newish data on remdesivir, but again, that is not in an ICU population, and it hasn't shown a mortality benefit. It does show that it cuts your hospitalization rate, but I would like to see stronger data before making that a strong therapeutic tool. We know that hydroxychloroquine doesn't work based on an observational study coming out of New York. We don't know if the tocilizumab or the steroids or the uh, uh, or any of the plasma products or any of them have any evidence behind them to work. Altered standard of care, definitely huge role of the point of care ultrasound in being able to go through the differentials of hemodynamic compromise, of respiratory failure, of blood clots, what have you. And we were lucky that we had enough ultrasounds and ultrasound experts in our team to be able to do this on a regular basis. The last thing, as you see this in your ICUs, you will notice that things move very slowly, and this has repercussions on management choices. For example, just the levels of sedation in routine life. We wake up our patients every morning for a spontaneous awakening trial and a spontaneous breathing trial as a bridge to getting them off the vent. This is tricky in a patient with COVID precautions, just because it takes easy 5 to 7 minutes to dawn and go into the room, and as you wake the sedation patient off sedation, self-extubation can be risky, and it takes a few minutes to be able to stop them from doing that. So plan and take care of things in a more paced. Um, Lastly, I cannot emphasize enough that you will need a multidisciplinary approach. You will need a lot of your colleagues to help you through a crisis with a novel virus such as this. So, for example, in the patients who would need long-term weaning off the ventilator, you should be building you might have built a tracheostomy team, a proning team to help position and reposition your patients every day, a palliative care team to help connect the families with the loved ones, in the ICU, procedure team to help with your central lines, your A lines, your intubations, and so forth. A dedicated renal replacement therapy team, given the high incidence of need for renal replacement and peritoneal dialysis, and of course, a site manager team that would assist with making sure their supplies and resources are where they should be.